Okay, I want to start by naming something that I think most people watching this already believe, even if you haven't said it out loud. The belief is this: if we build better models, we get better healthcare outcomes. So better architecture, better training data, better benchmarks, better guardrails. And eventually the AI gets good enough that it moves the needle on how clinicians practice. And that's not wrong exactly, but it is incomplete. And in healthcare, the gap between not wrong and complete is where a lot of real world harm can happen. This is kind of what I've learned from 20 years in science communication and the last several years deploying AI in medical education. The model's output is not the end of the pipeline, it's the middle. So between your LLM and a clinician changing how they treat a patient, there is an entire layer of translation. Someone has to take what the model produces and turn it into something that actually teaches, something that meets regulatory standards, and something that accounts for who the learner is and what they need to do on Monday morning. That layer is medical education. And right now, in most AI governance conversations, it's completely invisible. So that's what I want to talk about today. Not the model, not the data, the last mile, the part where AI output becomes clinical knowledge, and what happens when nobody is governing that translation. Let me give you a quick frame for what I mean by medical education in this context. Continuing medical education, or CME, is how practicing clinicians stay current. After medical school, after residency, for the rest of their careers, clinicians are required to engage with accredited educational activities to maintain their licenses. In the US alone, the system reaches over 1 million clinicians every year. And that content that goes into those activities has to meet specific standards. It has to be evidence-based. It has to be free from commercial bias. It has to be designed around identified gaps in practice, not just topics that sound interesting. And it has to be reviewed and validated by qualified medical professionals before it reaches a learner. Now AI is entering this pipeline, and it's entering really fast. LLMs can draft needs assessments, they can summarize clinical literature, they can generate learning objectives, write case scenarios, produce assessment questions, and they can do all of this faster and cheaper than the traditional process. Let me make this concrete. I work a lot on needs assessments for continuing medical education. A needs assessment is the research foundation of any educational activity. You're identifying what clinicians are actually getting wrong in practice, where the gaps are between what the evidence says and what's happening in the real world, and then you design education to close those gaps. Traditionally, this takes weeks. Reviewing clinical literature, analyzing claims data, surveying clinicians, and then synthesizing it all into a coherent argument for why this education needs to exist and what it needs to address takes quite a bit of time. But now an LLM can produce a first draft of that analysis in an afternoon. And sometimes, I would say most of the times, the draft is quite good. But sometimes it's not. And the ways in which it fails are very subtle, and they're becoming more and more subtle as AIs develop. I've seen AI-generated needs assessments that identified real practice gaps, but cited evidence that didn't actually support the gap they described. The citations were real, the studies existed, but the connection between evidence and the claimed gap was the AI's inference and not the actual conclusions from the studies. It looked rigorous, it read well, but the foundation was shaky. And if nobody with domain expertise had reviewed it carefully, that shaky foundation would have shaped an entire educational program. That's not a model failure in the way most people in AI think about model failure. The model didn't hallucinate. It made a plausible inferential leap that a human expert would not have made. And it presented that leap with the same confidence it presents everything else. I've been watching this play out across the medical education community. At AMA's Change MedEd conference in Chicago last year, they polled about 50 medical educators on where their institutions were with AI implementation. Most of the people in the room were regular AI users, but when we asked about their institutions, the majority said they were still at the stage of isolated experiments. A few people trying things in their own corner, no coordination, no governance. And when they were asked about the biggest challenges, the word cloud that was generated was telling: privacy, knowledge gaps, faculty development, appropriate use, not model performance, not technical limitations. The challenges were all about the human layer. Who knows enough to use this well? Who's setting the standards? Who decides what appropriate looks like? I saw the very same pattern at the Alliance for Continuing Education in the Health Professions Conference earlier this year. There were 16 sessions on AI, up from maybe 3 just 2 years ago, and the maturity arc was clear. Some sessions were still at the awareness stage, helping people understand what AI can do. But the conversations that drew the most energy were about governance. One session ran a live exercise where attendees used an LLM to walk themselves through a 10-point governance self-check for their own organizations. People pulled out their laptops, worked through the prompts, and by the end, the most common response to what will you do differently after today was create a policy. Not use AI more, create a policy. That tells you where the community is right now. So the problem isn't that AI is entering the medical education pipeline. The problem is that it's entering without governance structures that account for what makes medical education different from other types of content. A blog post can be wrong and the consequence is embarrassment. A marketing email can be off target and the consequence is a low click-through rate. But a CME activity that misrepresents the evidence or presents accurate evidence in a way that leads clinicians to apply it inappropriately can change prescribing behavior, and therefore it can affect patient safety. And the governance frameworks we currently have for AI in healthcare, they were built for model performance, for bias detection, for data privacy, which are all important. But none of them address the question, who is accountable for the educational quality of AI-generated clinical content? That is the gap, and it is growing. I want to offer a framework for thinking about this. It's called ART, and it stands for Accountability, Rigor, and Taste. I developed it through my work with medical writers, but I think it applies to anyone who sits at the intersection of AI and clinical knowledge. And before I walk through it, I want to name something. When people talk about AI governance, usually they're talking about the model. I'm talking about what happens after the model. Those are complementary conversations, but the second one is really not being addressed at the moment. So let's start with accountability. Accountability answers the question, when AI contributes to medical education content, who owns the output? This sounds simple, but in practice is surprisingly unresolved. If an LLM drafts a clinical case scenario and a medical writer edits it and a clinician reviewer approves it, who is responsible when the case contains a subtle error that leads the learner to the wrong clinical conclusion? In traditional medical writing, the answer is clear. The writer is accountable for accuracy, the reviewer is accountable for clinical validity, and the accreditor is accountable for compliance with standards. But when AI enters the workflow, those lines blur. The writer didn't generate the initial content. The reviewer may not know which parts were AI generated, and the accreditor may not have a framework for evaluating AI-assisted content at all. I participated in a debate on AI ethics at the Alliance conference, And one of the things that came up was this question of faculty-generated content. Medical education relies on expert faculty, clinicians who contribute their knowledge and their slides and their case examples. And increasingly, that content is being drafted with AI. So now you have a situation where the faculty member used AI, the medical education company may have used AI, and the final output has passed through multiple layers of AI assistance, and nobody has a clear picture of the full chain. Accountability means defining in advance who checks what and who signs off. It means making AI's contribution visible in the workflow, not hidden. And it means accepting that the human in the loop isn't a rubber stamp. They are the governance. Let's move on to rigor. So rigor is about evidentiary standards. AI can produce content that sounds authoritative. It can cite real studies, reference real guidelines, use the right clinical terminology, and it can still get the synthesis wrong. It might cite a study accurately, but miss that the study was retracted. It might present a guideline recommendation without noting that it applies to a specific patient population. It might combine findings from two different trials in a way that implies a conclusion that neither of the trial actually supports. For medical education, this is a particular problem because clinicians are trained to trust content that comes through accredited channels. The whole system is built on the assumption that someone has already verified the evidence. If AI is generating that content and the verification process hasn't adapted, we have a trust architecture that is no longer earning its trust. Rigor means building verification into the workflow, not bolting it on afterwards. It means treating AI-generated clinical content with the same evidentiary scrutiny you'd apply to a manuscript submission, not a first draft you can clean up later. And then there's taste. This is the one I want to spend the most time on because I think it's the least discussed and the most important. When I say taste, I don't mean aesthetic preference. I mean professional judgment, the kind that comes from years of experience creating educational content for specific clinical audiences. The ability to look at a piece of content that is technically accurate and well-sourced and say, this won't work. Not because the facts are wrong, not because the framing is wrong, but actually because the framing is wrong for the audience. Let me give you an example. Imagine an LLM generates a CME module on type 2 diabetes management. It pulls current guidelines, cites the right trials, and recommends SGLT2 inhibitors for patients with cardiovascular risk. Technically accurate, well-referenced, it would pass any fact-checking pipeline you could build. But the module is supposed to be designed for primary care physicians in community practice. And the way the LLM structured the content led with the cardiology evidence, the landmark cardiovascular outcomes trials, the risk reduction data, and it actually buries the practical prescribing considerations. When to check renal function, volume depletion risk in elderly patients, and when to hold the medication before surgery. A cardiologist reading the module would think it was fine, but a PCP seeing a frail 78-year-old next Tuesday needs the information prioritized completely differently. The facts are right, the pedagogy is wrong. And the consequence is a clinician who technically learned the guideline, but isn't equipped to apply it safely in their actual patient population. That's one flavor of taste. Here's another. I've seen AI generate a set of learning objectives for an oncology module that were technically well-formed. They used the right verbs, they were measurable, they ticked every box on the checklist. But the objectives were oriented around knowledge, what clinicians should know. The actual practice gap, the reason the education was being developed, was about clinical decision-making. what clinicians should do when they're standing in front of a patient with two reasonable treatment options and conflicting data. A knowledge level objective produces a lecture. A decision-making objective produces a case-based discussion. Those are fundamentally different educational experiences, and they lead to fundamentally different outcomes in practice. The AI had no way to know which one the learners needed, because that judgment requires understanding the practice gap, not just the subject matter. I want to give you one more example because I think it shows a different angle on this. At ChangeMed Ed, a team from Dartmouth presented an open access AI patient simulator that they built for medical students. It's a chatbot that plays the role of a standardized patient so students can practice history taking, doing a differential, communicating a diagnosis. And they were clear about something important. This tool is additive. It's a low-stakes practice layer before students see a real human. It does not replace the standardized patient. But here's what was kind of interesting. One of the clinical educators said that the students initially did not trust the AI's feedback. Students would say, of course I asked open-ended questions in the beginning. And then they would look at the transcript of their conversation with the AI, and this transcript showed that they hadn't. So the AI's record was more accurate than the student's memory of the encounter. That's a powerful educational tool, but it only works because someone with pedagogical expertise designed the scenario, chose the right clinical context for the learner's level, and defined what good looks like in the feedback rubric. The technology is impressive. The judgment that makes it educationally useful, that's human, that's taste. And at the Alliance conference, one of the speakers in the simulation track, Renee Wadsworth, presented research on cognitive offloading, the tendency to delegate reasoning to external tools. The data show that when people use generative AI, they report putting significantly less effort for critical thinking than when they work without it. And she said something that stuck with me. If you automate the reasoning, you automate the risk. That's exactly the concern with taste. If we let AI handle the educational design decisions, the framing, the audience analysis, the pedagogical choices, we're not just saving time, we're offloading the judgment that makes the education safe. And unlike a factual error that a reviewer might catch, a pedagogical error is invisible to anyone who doesn't have the expertise to see it. So taste is knowing who's in the room and what they need to do on Monday morning. It's the ability to restructure accurate information so that it actually teaches. And it's the ability to look at well-formed educational design and recognize that it's solving the wrong problem. No pipeline catches this. No benchmark, no evaluation metric, no red teaming protocol. The only thing that catches this is a human who understands the audience, the learning objective, and the clinical context well enough to know that technically correct is not the same as educationally sound. That human judgment, that taste, is not a nice to have. It is the governance in medical education. So where does this leave us? I think the AI governance conversation in healthcare needs to expand. Not replace what's already happening, but expand to include the content layer. Right now, most governance frameworks stop at the model. Is the model accurate? Is it biased? Is it safe? And those are essential questions. But I don't think they are sufficient because the model's output doesn't go directly to the patient. It goes into content pipelines. It gets shaped, structured, framed, and contextualized by humans, or at least it should, before it reaches the clinician who makes the decision that actually affects the patient. If we're not governing that translation layer with the same seriousness we bring to the model itself, we have a blind spot. And in healthcare, blind spots have consequences. One of the speakers at ChangeMed Ed made an observation that has stayed with me. He said that AI has, to a certain degree, developed knowledge. You no longer need medical school to answer a complex question about a complex disease. And he's kind of right. But what that means is that the value isn't in the knowledge anymore. The value is in what you do with it, how you contextualize it, how you teach it, how you make sure it reaches the right person in the right form at the right time. And that's the work of medical education, and that is the work that needs governance. So the ART framework is one way to start. We can define accountability chains before AI enters the workflow. We can apply evidentiary rigor to AI output the way we would apply it to any claim that's going to influence clinical practice. And we should protect the role of human judgment, taste, in determining whether content is fit for its intended audience. None of this is anti-AI. I use AI every day in my work. I teach other medical writers how to use it. I think AI is making medical education faster, more responsive, and in many ways better. But faster and better are not the same thing. And the question we should all be sitting with isn't whether AI can generate medical education. It's whether anyone will notice when it gets it wrong. Thank you.